Hi everyone and welcome to the next day of the 10 on 10 series. For the next 2 days, we'll be discussing 10 MCQs each of Path and Micro, which is going to be the drill which we followed in the 10 on 10 series 1.0 season as well. So before we get on to it, we are going to discuss the homework that I gave you yesterday. One was which cell similar to coilocytic cell is seen in renal cell carcinoma, that is chromophobe RCC. That also shows a razonoid nucleus with a perinuclear halo, but here in RCC chromophobe type, it is known as the plant cell. The next homework that we had was the new vaccine of Japanese encephalitis. So Japanese encephalitis vaccine is Genvac, which is a killed type of a vaccine prepared from the kolar strain, and it was a delight to learn so much of PSM in the comments yesterday, as all of you wrote everything about this vaccine. So keep the comments going and keep the homework going in the same manner, because this is truly revision that will help you recall things on the day of the exam also. Now let's move on to the next 2 days, that is clinical questions. Starting with the very first one is what microorganism is likely to be increased in a 26-year-old woman. The discharge given is thin homogeneous vaginal discharge with a fishy odor, and here you've got your buzzword, that is clue cells on pap smear, which makes it a case of Gardnerella vaginalis. Of course, we are talking about bacterial vaginosis. Before I discuss it, what would have been the case in Candida albicans on a pap smear? We can never ever forget the shish kebab appearance that Candida shows us, which I've taught you so many times, and I taught you recently in the images session of this 10 on 10 series also. So now let's discuss a little bit of bacterial vaginosis over here, and this is, as I told you, caused by Gardnerella vaginalis, which is anyway a simple but an often asked question. There are two criteria which we follow in gynae, and that is what I want to ask you. One I'll teach you, one you teach me, so this is going to be a mutual effort. The two criteria are named as Amsel's criteria and Nugent's criteria. Amsel's is lengthier, so let me teach this to you. There are 4 things that are followed in the Amsel criteria, and out of these 4, at least 3 out of 4 or all 4 of 4, so anything equal to more than 3 criteria present is going to be positive for Amsel's criteria. So what does it mean? The first one is to do with the vaginal pH being more than 4.5. The second is the discharge, which was described over here. It is a thin, grayish, homogeneous discharge which has an odor, and that odor can be enhanced further on doing number 3 criteria, that is the whiff test. The whiff test is that to the discharge, when we add 10% KOH, it is going to give a fishy odor, and that's also been a PYQ in gynae. Now let's talk about what would you see under the microscope. On a pap smear, we'll see clue cells. I'm going to show you pictures of a clue cells, but it's not 1 or 2 clue cells which will give the diagnosis. There should be at least more than 20% in the pap smear slide, then you will give the diagnosis. So out of these 4, even if 3 are present, we will say the Amsel's criteria is positive. So what are these clue cells? And here you have the image. So clue means it is going to give a clue. Once you look at them, you will get a clue that, oh yes, this is a case of bacterial vaginosis. And where are you seeing them? You are seeing them on a pap smear which is taken from the cervix. So of course you're going to see cervical cells. These are all the cervical epithelial cells. I hope you also remember, especially NEET PG students, in the cervix, the pink color cells are the superficial cells, the blue color cells are the intermediate cells. So I'm seeing a pap smear over here, but then look at these cells. On top of these cells, I can see this Gardnerella vaginalis, which is a cocobacillus, has gotten stuck on top of this cell. So it is stuck over here, which is basically giving a clue appearance, and it has made this cell very, very blurred or fuzzy. That is a clue cell, more than 20% of this, and that will be a part of Amsel's criteria. But is it that the bacteria will only stick onto the cells, or the bacteria would also want to go in the background? Of course it will go in the background also. So if you look carefully, I can see some which is looking probably like dirty material to you, but the bacteria is there in the background also. The bacteria is there on the cells also. When it is on the cells, I call it a clue cell. When it is on the background, it has made the background also blurry, and that is known as the filmy background. Both of these are questions that you can get in gynecology, of course. So coming back, Amsel's criteria I have explained, and your homework number 1 for the day is that you are going to type out Nugent's criteria. So this is a single line criteria which you are going to type and let me know what it means, because you're getting a lot of questions. A recent question on Nugent's was also asked, and hence it's your homework. Moving on to question 2, which was asked a lot by students, so I thought let's include it in one of the MCQs. So here we have a 64-year-old woman with a rapidly growing painless breast mass which is well circumscribed and mobile. See, the history, obviously age pointed towards a cancer, but when I saw the description of it, which is well circumscribed, it is mobile, and now I think maybe it is a fibroadenoma, which is more commonly seen in reproductive age group but can be seen when it is described this way. But let me go forward. They say there is a large lobulated mass Cystic and solid components are seen, and inconclusive FNAC. Now that's quite an important thing. If FNAC would have clear cut told me what for fibroadenoma, staghorn clusters for fibroadenoma, I would have been very clear cut in my approach, but they said that FNAC was inconclusive, so I'll have to read further. Histopathology shows hypercellular stroma. It's a stromal tumor with leaf-like projections. Now I'm not thinking of fibroadenoma. Leaf-like means I'm thinking of something to do with phylum, so I'm thinking of the Phyllodes tumor. And is Phyllodes tumor a stromal tumor? Yes, it is going to show me a lot of stroma. So they've asked you that what differentiates this from a fibroadenoma. Only if I would have read the last line first, I would have got the answer in the beginning, that they're not asking me about fibroadenoma, but what differentiates it from fibroadenoma. So like I said, that Phyllodes tumor is a stromal tumor. What do you think it will show you more? It will show you more of stroma because it is a stromal tumor, so it will show you high cellularity. Next, because the cells are more, of course the mitotic rate, cells are dividing more, so mitotic rate will be more. And of course it's a stromal tumor, so it is going to show me stromal overgrowth. The answer over here is all of the above. So ma'am, in surgery, can you elaborate that what exactly are we supposed to know for Phyllodes tumor? Firstly, you said phylum, so this is going to show you these leaf-like projections. I think you know the meaning of phylum, but why has that happened? What has grown so much that it has given this leaf-like projection? Again mentioning it is a stromal tumor, so it's the stroma that has grown a lot. For the Phyllodes tumor, the categorization is done as benign, borderline and malignant. There are three types of Phyllodes tumors, and what is this based on? Everything to do with stroma. How much is the stromal cellularity? Cells kitne hain? How many are the cells? How much has it grown? So now they say that in benign, borderline and malignant, it is mild, moderate, severe, mild, moderate, severe. But don't you think that this is a very subjective thing? That in benign Phyllodes tumor, the stroma will be everything minimal. In borderline, it will be moderate. In malignant, it will be severe. But what you might think as moderate, I might think as severe. There will be subjective variation. So ma'am, give us one criteria which is counting, quantitative, rather than this subjective criteria. Mitosis is going to be something which I will count, and I'll get to know whether it is benign, borderline or malignant. If I get to see less than 5 mitosis per 10 high power field, I will call it benign Phyllodes. If I get to see between 5 to 9 mitosis per 10 high power fields, I call it borderline Phyllodes. And if I get to see equal to more than 10 per 10 high power field, then I will call it malignant Phyllodes. So don't you think more than just knowing mild, moderate, severe, it is better that you do mitotic count and find out? And everything was written in the question over here, from cellularity to mitosis to stroma. So the answer is all of the above. Now what thing can be asked as a commonality? And this is not important for FMG students, but more for NEET PG students. That is, between fibroadenoma and between Phyllodes tumor, is there a common genetic mutation that can result in both of them? And that is the MET12 gene mutation. So question number 2 is also done, and we move on to question 3. The kind of topics that I've touched upon today, as I labeled them clinical MCQs, are not the usual general pathology or the usual cardiovascular system that I keep asking you. They are breast, they are pap smear, they are like a bone tumor over here. So these are topics which you study in other subjects more, and I want to correlate that with pathology. So now here we have a 30-year-old woman, and there is a 4.5 centimeter intramedullary mass which is present in the epiphysis of the distal femur. Distal femur and epiphysis. Clinically, only the first thing coming to my mind, epiphyseal tumor in the distal femur, means near the knee joint. I think of a giant cell tumor, but let's see if I'm right. Microscopic image has been shown. Obviously, it will be a little more enlarged in the exam. This has just gone very shrunken over here. But can you see those multinucleated giant cells out here? Yes. So this further tells me that, okay, yeah, this is a giant cell tumor. Epiphysis is going in place. Giant cells are going in place. Now they are asking you which of the following is true regarding this entity. So let's read. The lesion never demonstrates cortical destruction or soft tissue involvement. See, now first you'll have to tell me, is giant cell tumor a benign tumor or a malignant tumor? Because we tend to categorize it somewhere in between. It is an indeterminate or an intermediate category. So we tend to call this tumor as locally aggressive. So can it show cortical destruction? It can. Can it show sometimes soft tissue involvement? It can. So this obviously becomes a wrong statement. Option A is ruled out. Coming to the next, you called it a giant cell tumor. So this means means the giant cells are the cancer component, the neoplastic component. That is also wrong, which is the most common error done by students. Although I'll look at this photo once again, although what you see and you call it are multinucleated giant cells, because of which you called it the giant cell tumor, but that is just a reaction. Do you know that is not the cancer or the tumorous part of this particular lesion? The tumorous part are the cells which are showing me 1 nucleus. So that mononuclear component that I'm seeing in the center, that mononuclear component is the tumor element. So that is something which is very important to know. Although you call it giant cell tumor, but giant cells are not the neoplastic element. So option B is also ruled out. Coming to option D, which says that tumor is a high grade malignancy. I just now told you it's neither very low grade nor very high grade. It is somewhere in between. So this is also ruled out. The only correct statement over here is treatment includes therapy against rankle. Now what does this mean? Because when I'm talking about giant cell tumor or osteoclastoma, all this you already know that it is an epiphyseal tumor. It is occurring at the near the knee joint. So that means it is occurring near the lower end of the femur and the upper end of the tibia. So that all you know, right? But what do you see radiologically? We see the characteristic soap bubble lesion radiologically. That is very, very important for you to know. Why do you see those black holes? Why soap bubble? Those black holes, when I try to correlate it with the bone image shown over here, I realize there is a lot of blood, and blood of course will look blackish on an x-ray. So there is a lot of blood, there is a lot of cystic lesion and blood inside it. That is why you're seeing the soap bubble appearance. But ma'am, why has blood come? Blood will only come when the bone is being broken. And now you need to understand that which pathway got activated. Rank-Rankle pathway got activated. That is the reason that the bone is getting destroyed and there is bony destruction. So now tell me, what will you do in the treatment? I will stop this pathway. Automatically the destruction will be stopped. So what is the treatment? We give an anti-rankle drug, that is denosumab. And coming back to the question, treatment includes targeted therapy against the rank-rankle pathway, denosumab. That is the only correct statement that we have in the options provided. That is how you're going to approach questions in the exam. Moving on to a very, very quick question. If you have to differentiate on the basis of indices, flipping, going on to hemat, differentiate between microcytic, normocytic and macrocytic anemias, means you are basically talking about the size of the red blood cells. Which out of these tells you the size? It is MCV, that is mean corpuscular volume. And we know that the normal MCV, which you're going to revise with me, normal MCV, which tells us about the size, is between 80 to 100 femtoliters. So when we said normal size, that is 80 to 100 femtoliters. When we said microcytic, that is less than 80 femtoliters. And when we said macrocytic, that is more than 100. So 80 to 100, if you know, is normal. Less and more you can easily do. But finish off the other values also. What is mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration? So how did we learn this? You start from 27 and you end at 37 and you put a break in between. So 27 to 32 picogram is going to be MCH. And if you start from there, 33 to 37 gram per deciliter is MCHC. So these are all the normal values. Again, something asked a lot in the exam. Let's move forward to question number 5. This is the homework that I gave you all the way back on day 1 of this series, where I asked you what is the role of hepcidin in iron regulation, and whatever I gave you that day I am putting up as questions today. So what is hepcidin? Hepcidin is something, let us read. Does it promote iron absorption? Tell me, is hepcidin a positive regulator of iron or is it a negative regulator of iron? All of you had told me correctly in that comments and the homework that ma'am, it is a negative regulator of iron. It is never ever going to promote iron absorption. In fact, it is going to inhibit the iron absorption. So I'm not revising the entire absorption of iron because that's an entire, an entire video lecture in its whole. But I'm going to touch upon the basic points. Let's do a 30 to 40 second quick recap of the entire iron absorption. Let's see if we can achieve this in half a minute. Challenge for me as well. So this is iron absorption, and in which part of the intestinal cell does this occur? This occurs in the duodenum. So the iron that we have in food, we can't absorb it directly because most of the iron that we have in food is the Fe3 plus form, that is ferric. But for iron to be absorbed, it has to go via a transporter known as DMT1, known as divalent metal transporter, which will only allow things with 2 valencies, and iron is having 3 valencies here, so this cannot not pass through DMT1. You will first have to convert it. You will have to convert it into Fe2 plus, and that is done by the enzyme cytochrome B reductase. Now this Fe2 plus will be allowed to enter through DMT1. But do you want to keep the iron in the duodenum? No, I want it to go to the bone marrow. That is where hemoglobin production is occurring. So iron is now going to go via a port which is known as ferroportin, and now this iron has come into the blood. And now we are smart because we've got Fe2 plus, we've done that pathway passing through DMT, passing through ferroportin. Now put it back into Fe3 plus. Who is going to convert it back in the body? It is hephaestin and ceruloplasmin, because it is this Fe3 plus which is going to go all the way up till the bone marrow where the hemoglobin production is occurring. But Fe3 plus says I can't travel alone, I will need one travel buddy, and that travel buddy is transferrin, through which it attaches and it goes till the bone marrow. So now tell me, if you are saying that hepcidin is a negative regulator of iron, which part of this cycle is it going to inhibit? It is going to inhibit ferroportin. So if I had to mark, it is this pathway that hepcidin will inhibit. So imagine you are eating a lot of iron supplements, green leafy vegetables, iron rich foods. That iron is going to the duodenum, but is it getting absorbed into your blood and in your body? No, because who is not letting that happen? That is hepcidin. So hepcidin is a negative regulator of iron. In fact, it is called as the master regulator of iron. And if they ask you where is it coming from, the source of course is hepatic. What is its function? It's an inhibitor. Hepcidin comes from hep or hepatic. It is an inhibitor, which means that whatever food you are eating, it is going to inhibit the absorption of iron, because it will not let ferroportin work. So if you're not able to absorb the iron, whom will you go to? You will go to your bank, your storage bank. Your storage bank is what? Ferritin. So you will ask ferritin, can you lend me some money? Can you lend me some iron? But hepcidin is that hijacker. Hepcidin says, I will not, will a hijacker allow you to use your bank account? No, your hijacker will freeze your bank account. So will you be allowed to use the iron from your stores? No, it will inhibit the release of iron from the stores. So imagine you are eating a lot of iron, that is also not getting absorbed. You have a lot of iron in your bank account of ferritin, that is also not getting absorbed. So it is like water all around and not a drop to drink. That is the situation here. Iron all around and not a drop to use. That is what hepcidin is doing over here. So remember this concept. Coming back, it is a negative regulator of iron. It inhibits the iron absorption. Moving on to question number 6 over here, which is a favorite with the students and the examiner, where you have a totally different organ, a 33-year-old female coming with the case of acoustic schwannoma. As soon as I say acoustic schwannoma, usually they talk about bilateral acoustic schwannoma. That is a syndrome known as neurofibromatosis 2. So neurofibromatosis 2, further they have mentioned there are pigmented lesions present, because we know that neurofibromatosis 1 and 2 both show cafe au lait spots, so that is also going in favor. On radiological investigations, there is a non-infiltrative brain tumor that is present with areas of calcification. See, whenever they say calcification, that is seen in 3 brain tumors in general. Number 1 is less heard of, that is craniopharyngioma. The next 2 are the ones which are your favorite. The O is the one with the fried egg appearance, that is oligodendroglioma. And the third one is meningioma. So the answer has to be one of these. As soon as they say positivity for progesterone receptor, we know that we are going in for meningioma, because this is the tumor that they're talking about. They said non-infiltrative, matlab it is arising from the meninges. One homework I have already done for you, because the syndrome that they have mentioned over here is neurofibromatosis 2. This is a meningioma which is seen in neurofibromatosis 2. So I've done half of your homework, why don't you do the rest of the half? Radiologically, when we see meningioma, what is that sign that you see? Very classical name which I've taught you earlier. And now that I've told you the syndrome, can you tell me all the brain tumors that come in NF2 which you had learned as a mnemonic miss me, so that you are going to tell me what is miss me. So 3 homeworks for the day, which I'll summarize in the end for you to recall as well. But coming back, why is this related to progesterone receptor? Because this is very commonly more seen in females, and the reason is that it is dependent on a hormone, that is progesterone. Coming back, if I had to see meningioma microscopically, all the tumor cells would also be going goal, means wrapping around each other, and that is known as whirling of the tumor cells. Can you see the tumor cells are trying to make these round circles? So tumor cells are also going goal, and then what is that calcification that is also seen going goal? These are all the samoma bodies, calcification, which we've read so many times. So this is a very, very important question that has been asked in the exam. Let's move forward to question number 7. And this is another thing which I gave you in the images PDF, but I didn't discuss it. So today I am discussing it with an MCQ. What is the composition of the characteristic finding that you see over here? What is the organ? Okay, it's a liver biopsy. So my focus shifts towards hepatobiliary system. There's a chronic alcohol abuse in a 45-year-old man. Maybe this is alcoholic liver disease. So there is abdominal pain, jaundice, malaise, liver enzymes are elevated. I can see necrosis, and with necrosis, neutrophils always come. So all of this is mentioned. I still think this is a case of alcoholic liver disease where liver damage has started. Now they've asked you, what do you see over here? Now no one will say alcoholic liver disease shows fatty change. That is obvious. I can see the khali fat areas. But what else? In this photo, I can see there are some extra. See, everything in pathology is pink and blue. But here I'm seeing something little more pink. I hope you're on the same line as me. So there is something little more pink, blobs, some spots in between which are coming more pink. Now this is not a spotter that's gonna come to you. When you see such kind of pink blobs and you have a liver history given and an alcoholic liver disease given, what you're thinking about are the classical Mallory-Hyline bodies or the Mallory-Denk bodies. The earlier name was Mallory-Hyline. The new name is Mallory-Denk bodies. They've asked you the composition and they are made up of cytokeratin 8 and 18. So what is that flashcard about this that you have to know? The old name Mallory-Hyline bodies, the new name Mallory-Denk bodies. What are they made up of? CK8 and 18, that is cytokeratin 8 and 18. So hota kya hai, ma'am? What is cytokeratin? Cytokeratin is present inside the cells. It is like, you can say it's the backbone of the cells. It is an intermediate filament. So there has been a previous year question where they gave you the same thing. Students made the diagnosis of Mallory-Hyline bodies, but CK818 they couldn't find in the options, because in the options they had written the composition is intermediate filaments, and that was the answer. So you must know the meaning of whatever you are reading. Okay, so is Mallory-Hyline bodies only seen in alcoholic liver disease is the next question, and of course not. It is non-specific. This is the famous mnemonic. I've not made it. I don't know who made it. It's been there since decades. Every student learns it this way. It is seen in New Indian Watch. What is New Indian Watch? N for non-alcoholic liver disease. And alcoholic liver disease means it's seen in a lot of diseases. It's non-specific. So new is done, non-alcoholic and alcoholic liver disease. Indian, of course, the name only has it, Indian childhood cirrhosis. The next W, the only disease that I know of is Wilson disease, the copper overload. A, think of an enzyme deficiency in the liver. It is alpha-1 antitrypsin deficiency. T, of course, tumors of the liver, which of course you will think of. The first tumor coming to your mind is hepatocellular carcinoma. C, if the bile stasis occurs, known as cholestasis. And H, please do not make an error here, because students say W for copper overload, so Wilson disease. H must be iron overload, so hemochromatosis. No. H stands for hepatic or primary biliary diseases, because Mallory-Hyline or Denk bodies are not seen with iron overload. They are not seen with hemochromatosis. So what are the two conditions? This has been a NEET PG PYQ. I know students skip this chapter as a whole. So you know these PYQs maybe you've skipped, and this is your golden opportunity to cover up these. So please note, it is not seen, number one, in hemochromatosis. It is not seen in secondary biliary diseases, because I characteristically wrote primary. So over here, learn New Indian Watch, and where is it not seen? Hemochromatosis not seen, secondary biliary diseases not seen. Moving on to the next question that you have, which is number 8. There is again coming back to breast pathology. 55-year-old man with a solitary breast mass. No, it's not a mistake. Male breast cancer can be given to you as a question. Let's read further. There are malignant cells, so it is male breast cancer only. Immunohistochemical procedure shows tumor cells are positive for HER2/neu and cytokeratin. See, most carcinomas are always positive for cytokeratin, so that is not something I'll focus on. But positivity for HER2/neu is very important, because then I can give targeted therapy like trastuzumab. Also, they have said negative for estrogen receptors. So now they are asking you that what is the most likely diagnosis that you have over here. If I look at all the options given over here, the most common in general is going to be ductal carcinoma in the breast, whether it is a man or a woman. So my best answer over here will be invasive ductal carcinoma. But now what I further have to also see over here is that what is this immunohistochemical staining that was given. So for immunohistochemistry, we follow a molecular classification in breast cancer, although the use that I'm doing over here is of three things: ER for estrogen receptor, PR for progesterone receptor, and HER2/neu of course is another marker. So I'm using immunohistochemistry, but this classification basically was not based on immunohistochemistry. The classification basis was the gene expression profiling. So if a question comes, what is the basis of molecular classification? It is gene expression profiling. But now what we are using as a surrogate classification is immunohistochemistry. I hope you remember immunohistochemistry is the same stain which I always taught you gives a brown color that you have in pathology, which is also a PYQ. Now coming back to this classification, we have luminal A, luminal B, HER2 rich and triple negative. Let's start with the easy one. Common sense tells me that triple negative will be all three markers negative. HER2 rich of course will only be HER2/neu positive. So if you have one category which is going to be only HER2/neu positive, then you will have a category which are ER/PR positive. So luminal A and luminal B are the ones where ER/PR is positive and HER2/neu is negative. So ma'am, what's the difference between luminal A and B? To differentiate the same, we will be doing Ki67, which is what? Ki67, you studied it in path and in surgery. It is a proliferative marker. If Ki67 is less than 14%, this means the tumor is proliferating less and it is luminal A breast cancer. If Ki67 is more than 14%, tumor is proliferating more and it is luminal B. Before I move on, because we have a category called triple negative, students often ask me that, ma'am, is there a category called triple positive also? So luminal B sometimes, I'm not saying always, sometimes can be HER2/neu positive, and that of course will make it a triple positive breast cancer. You've got the classification in place. Now which type of cancer comes under which of these? When I'm talking about triple negative, NE for negative, so ME breast cancers come under it. That is medullary carcinoma breast, metaplastic carcinoma breast are triple negative. Then when we talk about HER2 rich, the only one cancer that you have to know is the apocrine carcinoma of the breast, which is HER2 rich. After that, the Dustman category, or the most common that we call, is going to be luminal A, which means tubular carcinoma, luminal A, mucinous carcinoma, luminal A, papillary carcinoma, luminal A, invasive lobular carcinoma of the low grade type is also luminal A. Then what comes under luminal B, ma'am? Anything that is low grade with a low Ki67, I can put in luminal A. But now instead of low grade, if I convert it into high grade, it will go into luminal B because the Ki67 and proliferation is more. So low grade ILC comes under luminal A, but high grade ILC or invasive lobular carcinoma comes under luminal B. All of this is the usual profile that you get. Molecular classification, we are doing immunohistochemistry, but the basis was gene expression profiling. So coming back to question 8, the most common cancer both in men and women is going to be invasive ductal carcinoma. But I have question 9, which is going in continuity with this question only, and that is saying, in the question above, that is male breast cancer, which of the following is thought to play a role in the development of cancer? Overall, if you ask me which is the most common genetic alteration overall in cancers, breast cancer, which is of course more common in females. So if you ask me from the familial point of view, so from familial point of view, it is BRCA1. Always. But when you're talking about male breast cancer, like in this case, it is BRCA2 mutation which you see in male breast cancer, which is the answer over here. Continuing the same, because this time in the INI CT exam, there was a question on genetics of breast cancer. Familial breast cancer genetics, most common is BRCA1, then BRCA2. But if they ask you what is the most common gene involved in sporadic breast cancer, and that is going to be P53 gene. So for familial or inherited, it is BRCA1 mutation. For sporadic, it is going to be P53 gene mutation, or policeman. Question 9 is also done. Moving on to the last question, another organ which you don't study too often in pathology at least, is a 52-year-old woman complaining of swelling in the anterior portion of the neck. First thing coming to my mind is thyroid. Let's see further. She noticed this 6 months ago, and except for some discomfort during swallowing, there is not any other significant report that she is telling us. Physical examination shows symmetrically enlarged thyroid. Even if I stop here, because after this all that's left is a thyroid biopsy, symmetrically enlarged thyroid will never be a tumor, because adenoma or any kind of tumor will, if you draw this to be the thyroid, tumor will be a solitary nodule or a lesion. At least the benign follicular adenoma is ruled out. Now I'm left with Graves' disease. Don't you think the patient, Graves' disease is a hyperthyroidism? So there will be some other complaints. Maybe there is a protruding of eyes, maybe there is excessive sweating. All these features of hyperthyroidism will be mentioned, not there. Hashimoto's thyroiditis, on the other hand, is hypothyroidism, maybe weight gain, menstrual irregularities. That is also not mentioned over here. So now when I look at the thyroid biopsy also, all that I see are large thyroid follicles, no special finding. This becomes a case of goiter, and it is non-toxic goiter because I'm not seeing any features of hormone imbalance also over here. So let us elaborate further. I mean, a non-toxic goiter I can even analyze on the basis of the history. But what would have the photo been if it would have been a case of Graves' disease and Hashimoto's? In hyper and hypo, how would this photo have changed? Firstly, why did I make this the thyroid apart from the history? Because thyroid normal photo can also be given to you in the exam. In the thyroid, these round structures that you're seeing, these are the thyroid follicles. So what is the lining over here? If you look carefully, these blue color cells which are lining, these are the thyroid follicular cells. What is present inside pink material is going to be the colloid, and outside the thyroid we have another bunch of cells which are known as the parafollicular C cells. Tell me, normally what do parafollicular C cells release? They release calcitonin, which is very important for you to know from physiology point of view. Normal thyroid. These are all the thyroid follicles. They have beautiful pink color colloid inside them. Okay. But now what if this thyroid gland starts working more? What if there is a case of hyperthyroidism? I will have Graves' disease in this person. Now look at the color of the thyroid. The entire thyroid gland is involved and it is beefy red. It's like as if it's on fire. It's looking as if it's fiery, beefy red in color because it's producing a lot of hormones. And now can you see what has it started doing to the colloid? Firstly, are you seeing those round thyroid follicles? No, it looks as if the thyroid gland is working overtime. Look at these projections it has started making. It has become extremely hyper. The color is also very hyper and red. Over here also the appearance is looking very hyper, and then I can see it is eating the colloid as if you're trying to scoop white areas. If you look carefully, it is trying to scoop out ice cream. It is trying to eat the colloid, and that is known as scalloping of colloid. So please note, if a beefy red thyroid with scalloping is seen, I will think of Graves' disease, hyperthyroidism. Tell me the other way around, ma'am, what if it's a case of hypothyroidism and you're thinking of Hashimoto's thyroiditis? So look at it obvious. See, it's not a tumor. So it's not that I will get a solitary lesion, not at all. I will see a symmetrical diffuse enlargement of the thyroid, whether it is hypo or hyper, the entire thyroid will be involved. Okay. Coming to the next, thyroiditis, which tells me there is going to be a thyroid element and then there is going to be an itis, means inflammatory element. The thyroid element are all these pink follicles that you're seeing over here, which is obvious. The inflammatory element is lymphoid cells. Why? Because this is an autoimmune disorder. All autoimmune disorders, whether it is SLE or whether it is Sjogren's syndrome, whether it is Hashimoto's thyroiditis, they always show you lymphocytes. And over here, these blue color lymphocytes have as if they have started making pura lymph node over here. That is how florid this lymphocytic infiltration is. So now tell me, how do you identify a case of Hashimoto's thyroiditis? Ma'am, pink color wala thyroid is seen. And then itis means inflammation. Which inflammation? Lymphoid inflammation is seen. But what is the hallmark feature of Hashimoto's thyroiditis? Hallmark feature is Hurdle cells, also known as Ashkenazi cell. कैसे identify करते हैं? These are the pink, very pink cells in thyroid. Why are they so pink? Because they contain a lot of mitochondria. Now, my last question before we end today's session is going to be that Hashimoto's can result which two cancers? Depending on, see, it has thyroid, so it can have papillary carcinoma thyroid risk, and itis means inflammation of lymphoid, so it can have a lymphoma, and that lymphoma is known as the maltoma. So these are the two tumors that can have, a predominance in Hashimoto's in the future as well. Well, having said that, nothing of Graves' disease, scalloping is not seen, Graves ruled out. Over here, no thyroiditis element or Hurdle cells are seen, Hashimoto ruled out. This is a simple case of non-toxic goiter. Well, with that, we wrap up today's 10-question clinical MCQ session. The homeworks, I think you know. Number 1, you have to tell me about what is Nugent's criteria. Second, you're going to tell me regarding meningioma on radiology, what sign you see. And in terms of the syndrome, because we have neurofibromatosis too, what are the brain tumors under it? That is the Misme mnemonic. So I'll be meeting you again tomorrow in the next session where we'll have 10 clinical MCQs of microbiology. And because all of you are facing a problem with bacteriology, be ready that these 10 are going to be very heavy with bacterio, not to scare you, but to give you more practice before the exam. See you in the next session, waiting for the answers.